The week ending June 21st has a theme, like all weeks seem to do. And this one, I think, is that ideas have consequences. So, what does that mean? It means a decision made in an office shows up weeks later, maybe as a body count. A flu requirement drop becomes an outbreak with a fatality. An easy exemption process becomes the largest measles outbreak in 3 decades in Pennsylvania. A doubt from the top becomes falling vaccination rates. So the thread of the week is that ideas and ideology have downstream consequences for real people. The Ebola outbreak in the DRC continues to be the top story. It's the dominant global story, and it's been present every single day that I've been talking about. The outbreak increased steadily and is now the third largest Ebola outbreak ever recorded. A containment failure driven less by the virus than by the broken conditions around it. So, what are some key points to keep in mind this week? Cases climbed across the week from around 800 up to close to 900 now. Again, this is likely an undercount. There are over 200 confirmed deaths. Contact tracing is failing. This is going to be the key way that this outbreak is extinguished. I see contact trace rates around 56%, with maybe 28,000 contacts untraced. You are not going to be able to break a transmission chain with that many untraced contacts. You are going to have no idea where the virus is going to pop up. If you can't see the virus in terms of these transmission chains, you can't stop it. What this is also is a complex synergistic disaster. So people keep asking, why can't they just fix this? And you have to recognize that where this is occurring, 1 in 5 people lack clean water. So how can you keep yourself free from blood and body fluids if you don't have clean water? Ongoing violence is continuing. It's actually overwhelming hospitals. The Red Cross is talking about the fact that their surgical suites are still going because there's violence from these militias that control these provinces where the outbreak is spreading. People are going to traditional healers because they don't recognize Ebola as an infectious disease. There, they get some sort of treatment or counseling, but that doesn't stop Ebola. The people get sicker. They end up coming to the hospital with more symptoms, more contagious, and less likely to survive. Patients are actually then fleeing these Ebola treatment units. Why? Because there's no food to feed them. You have to keep in mind that Ebola is probably on a long list of things that can kill people there, and it's not number one. And they know it's not number one. So if your hospital doesn't have food, I don't see how they're going to keep people in the Ebola treatment units. The burial issues continue to be a problem where people are dealing with the dead bodies and handling them. Remember that viral load peaks near death. So there's lots of blood and body fluid in a dead body. This is projected now to burn for probably a year or more. In the past, it burned like 2 years in that area. There are a few bright spots. There are clinical trials with remdesivir, monoclonal antibodies, vaccines that are getting kind of spun up. Dr. Stafford, the American surgeon who was treated in Germany, he's now back in the United States. The G7 has made a commitment to a coordinated response to the Ebola outbreak. There's been advocacy to use the monoclonal antibody that Dr. Stafford received more broadly to make sure that they have the logistics to be able to deliver it there. It's clear now that vaccines are going to reach trials within months, which I think really shows a concerted effort to do real-time research during this outbreak with a rare species of Ebola. The WHO also released supportive care guidance, like how to replace IV fluids, or how to manage electrolytes, blood pressure control. All of that's going to be very important in decreasing the mortality if people go to Ebola treatment units and if they're stocked and if they have food. And but keep in mind though that overarching, Ebola creates distrust and denial wherever it shows up. The idea here is that some people think that containment response can succeed by chasing the virus alone. It's clear that it's not going to happen. If you can't fix the food, the water, the security in a fragile, neglected region, you're going to have exactly what you have. People fleeing treatment units for lack of food. Contact tracing collapses, and the outbreak grows to the third largest in history, and now is going to burn for a year or more. Ebola is interacting there with a whole bunch of different other factors, which is making this very complex. So the next story I wanted to mention is RFK Jr. and the dismantling of the US vaccine infrastructure. I've talked about this a lot. This is ideology that's been installed at the top of HHS, and that ideology is an anti-human ideology, and it's producing measurable damage across the entire vaccine system. ACIP, the Advisory Committee for Immunization Practices at the CDC, reformulated and gutted by RFK Jr. This was something that he planned to do. He put his own cronies there. And I guess the major factor of whether you could be on that committee was whether you agreed with his anti-human ideology, with at least one exception. A judge blocked this move, and RFK Jr. is trying to now expedite the ruling to get it fixed. Senate Democrats are demanding an accounting. Schumer is calling to restore the CDC. All of this is really insufficient. If RFK Jr. remains in charge at HHS, all of this doesn't matter. It's just politics. If he has the ability to take his anti-human ideology and have it instilled within HHS, it doesn't matter if the Senate Democrats cry or somebody wants an accounting. There's enough accounting already. You know what he did. You know what he was going to do. He's telegraphed it. So it really strikes me as just, I don't really know what it is. It's completely futile. The other things about RFK Jr. is just how inconsistent he is. So he's a non-physician. He doesn't believe in the germ theory of disease, that infectious microorganisms cause infections, but yet then he issues a hantavirus quarantine order for someone, overruling the CDC's own hantavirus expert who said it was unnecessary. So what is this quarantine for if there's not a germ theory of disease? I don't really understand that. Like, how can he even believe in quarantine if he doesn't believe in the germ theory of disease? I don't know why anyone just doesn't ask him that straight. Why did you issue a quarantine order if you don't believe in the germ theory of disease? We're seeing one of the fruits of his labors or his misdeeds, the hepatitis B vaccine uptake is falling, more in females than in males, correlated with vitamin K refusal. All of this traced back to RFK Jr. reformulating childhood immunization schedules, not based on science, but based on his nihilistic irrationalism. The University of Maryland's Vaccine Center reportedly stopped working on mRNA vaccines. Why? Because RFK doesn't like them. Who cares what RFK doesn't like? If RFK doesn't like something, it's probably a good sign that it's something that's good, because he is the opposite of virtue. And if you look at, but it's interesting because he's doing all of this stuff and people are caving to him. Yet if you do they did a survey of 13 red states and the majorities actually support vaccines. So when you see all of these people online, and I don't actually urge you to read the comment sections on my videos, that's not actually reality. Those are people that are very deluded on these issues, but very loud and very annoying. So what's the idea here? The national vaccine policy is being bent to one official's irrational, nihilistic, anti-human ideology. And if you have that type of an ideology, it's going to come with a cost. So we have an ACIP that's completely dysfunctional. mRNA research, which is the most promising infectious disease research we've seen in a long time that saved the world during COVID, is halted. Hepatitis B vaccine uptake falling. One of the best vaccines we have prevents liver cancer, liver cirrhosis. And you have the whole scaffolding of vaccination degraded from the top down. And remember, this was done precisely. RFK Jr. knew what he was doing. He announced he was going to do it, yet people like Senator Cassidy voted for him, sanctioned what's happening here. And now I'm going to move on to the measles resurgence, which is related to this. This is the disease on the ground. This is, I guess, the flashpoint of all of this anti-vaccine ideology. There are hotspots all across the country. Buckingham County, Virginia, Amish Mennonite communities in Lancaster County, Pennsylvania, and Lebanon County, Pennsylvania, where some Mennonite schools have under 50% kindergarten vaccination rates. Walla Walla County, Washington, 7 cases this year after 0 for multiple years. That's clearly been attributed to ideology spreading. Pennsylvania, largest measles outbreak since the 1990s. And the interesting thing is, some of these pockets, like for example in Pennsylvania, Amish and Mennonite populations have had lower vaccination rates. And we've always had people traveling to hotspots for measles outside of the country. So in Europe, for example. What's different now? It's our vaccination rate or resilience. The fact is, the circles that kind of surrounded Amish and Mennonite communities traditionally had higher vaccination rates, so you didn't see it spread as much. Now, what's changed is all of that kind of barrier has been lowered voluntarily. So now these enclaves of unvaccinated individuals are going to be kindling for outbreaks to occur. In Pennsylvania, in relation to this, there is a bill to make it easier or harder, actually, and get rid of the ease of getting a vaccine exemption. PA currently has one of the easiest exemption processes in the country. There is a bill to make it more difficult where they have to talk to a physician. I think that's a good thing. I think schools should be run competently, and competently means safely and not as pest houses, like some of these schools are becoming in Pennsylvania. Lastly, Utah is kind of a focal point with the decision on the elimination status of measles in the United States, because they've been dealing with cases since June of 2025. The question is, are those the same strain? Is it the same outbreak? That's what's being adjudicated right now. But the fact is, they've had 680 cases there since 2025, June 2025. Even if it's not the same outbreak, they clearly can't handle measles there. And one of the pediatricians was quoted in an Associated Press article saying, I don't know that we get it to end. And I think that's what we're facing, that measles is reestablishing endemicity, not because of a failure of technology, but because people turned against the technology. The idea here is that people think that vaccination is optional and easy exemptions are harmless. Pennsylvania has, as I said, one of the easiest opt-out processes. What's the consequence? Pennsylvania now has the largest measles outbreak since the early 1990s. We have multiple low vaccine level enclaves all around the United States that are going to be kindling. So the consequence here is going to be we lose measles elimination status. But even if we didn't lose it, even if that wasn't a thing, we clearly can't control measles in the United States anymore. It's returned. It is endemic. It is becoming more and more common. So the next thing I wanted to talk about was influenza and mRNA vaccines. The VRBAC committee at the FDA, the Vaccine Advisory Committee, unanimously voted to approve Moderna's mRNA flu vaccine, which just a few months ago, the FDA declined to even review. I think this is a great development because it would be the first mRNA flu vaccine in the United States. There is one approved in Europe by Moderna. And this matters beyond seasonal influenza because an mRNA vaccine platform allows rapid strain changes in a pandemic, or if something comes up in seasonal, a flu late, and it's too late to switch the formulation in the egg-based vaccines. This is why mRNA vaccines are so valuable. And I think this will set a new standard for how we pick strains and really increase our resilience to pandemic influenza just to have an mRNA vaccine platform approved for influenza. Other things about flu vaccine, people think, it doesn't work, it doesn't do good things, but it does. Even if you get the flu. Because remember, flu doesn't just stop with influenza. It's not just the muscle aches and pains and cough and fever and sore throat. There is inflammation in your body that occurs when you get influenza, and that leads to cardiovascular events like heart attacks, like strokes. And basically, flu vaccine, if you're vaccinated, yeah, you might get flu, but you're much less likely to have a cardiovascular mortality event. Like 0.77 is the hazard ratio. So that's a 23% reduction. So that's really important. The COVID vaccine does something similar as well. And interestingly, how just to illustrate the progress with COVID, flu has a 43% hospitalization rate, higher hospitalization rate than COVID. That just shows the progress that science and medicine have made with COVID. And it also should give you pause that influenza still exacts a major toll. Another thing about flu, secondary bloodstream infections with flu triples mortality risk. So flu leads to such dysregulation of your immune system that you can get a secondary bacterial infection. And secondary bacterial infections were the major cause of death in 1918. If it's in your blood, 3x mortality risk. The flu vaccine, I talked about inflammation and decreasing risks of heart attacks. It also decreases risks of Alzheimer's disease. 55% less risk with individuals getting the high-dose flu vaccine in the 2 years after they got it. So there's many downstream effects of the flu vaccines. Stops influenza, makes it less likely you get infected, makes it less likely your case is bad, makes it less likely you die from influenza, decrease cardiovascular events, decrease Alzheimer's. So you would think this is a great thing that everybody should be getting. But yet their Secretary Hegseth from the Defense Department or the Department of War. So he ended the military's flu vaccine requirement. So what happened? It was great, right? No. Major outbreak at Lakeland Air Force Base. Only 40% of recruits are getting vaccinated now because Pete Hegseth thinks it's macho to not get vaccinated against influenza. Now they have a major outbreak with a fatal case. Who would have thought? So what's the idea? That soldiers don't need a flu vaccine requirement? That's the negative idea here. The positive idea is that the U.S. needs an mRNA vaccine platform. You see, both these ideas have consequences. The flu outbreak occurred at Lakeland Air Force Base, and now we have the Moderna mRNA vaccine poised within reach in the United States. I wanted to also mention long COVID. There is a lot of unsettled science here, but there's a lot of things happening every day with long COVID. A nebulous umbrella term likely covers more than one distinct condition, but it is real and it's costly, maybe like $1,300 per year for someone that has long COVID. If you have a long COVID diagnosis and you're a male, you might have a mortality signal there that you're more likely to die than a female with long COVID. So clearly there's some sex interaction with this diagnosis, but the definitions are so loose because the science is so early that it's hard to read much into that. We also know more cardiovascular disease occurs in people with long COVID. And we've known that people who get long COVID, we're trying to understand why they get it, who they are, they get it. And pre-existing mental illness like depression, anxiety, that had always been a signal, but also pre-existing physical illness raises the risk as well. Mental illness maybe more, but physical illness, if you had some underlying physical illness and got COVID, more likely to get long COVID. The mechanism really is unknown. So I think that one of the ideas here that I want to push back on is that if this is poorly defined and it's a catch-all condition, they're trying to manage it like a single disease, and you can't. The data is going to stay muddled and contradictory. We're not going to have any kind of integrated view of long COVID or the subtypes of long COVID until we get better with defining what we're talking about. The science is not going to be able to deliver clean answers. And patients with genuine health problems are left in limbo because we're still early on in understanding this, and there's a lot of definitional work that needs to be done. And lastly, I just wanted to mention West Nile virus. I've talked about it before, that we're in West Nile season now. There was a good story in the CBC, the Canadian Broadcasting Corporation, talking about the fact that in 2025, Canada had 9 deaths. And you might think, oh, these mosquitoes can't survive in Canada, it's cold, but they do. And one of the articles talked about a person who died of that, and actually was one of my friends in Toronto, his neighbor. So this is a real risk that you're going to hear more about. The big point that I want to leave you with is that you have to really recognize that all of these things are not just without consequence, that all of these policy decisions trickle down to actual real people getting real infections, like the Air Force recruits on Lakeland Air Force Base, like the kids in Utah who are getting sick, like the physicians who are getting harassed for opposing RFK Jr. So that's everything is downstream of these ideas, and they have real world consequences. So think about those.